phase. I'm just going to whip through these normal ones so you can like see the range that we get. All right. So this is late proliferative phase, and the glands are becoming tortuous. So tortuosity begins before we get into secretory phase. All right, so this is like right at that midpoint. And who can remember what percentage of glands have to have subnuclear evacuation before we turn it into secretory? In the chat, what percentage of subnuclear evacuation do we need in glands before it becomes secretory? Uh, 100% says Adriana. Have you got an advance or decrease on that? I won't accept 200% because it was high, 100%. Well, the answer is 50%. Okay. So this is where we officially say that the subnuclear evacuation turns it from proliferative to secretory. And you'll notice that different parts of this endometrium are maturing at different places, different stages. So here at the top, we've got this proliferative stuff, but in the midpoint, we've got subnuclear evacuation. So this tells us the progesterone's around. If you can't tell and you think, oh God, is this 40% or 60%? Just put mid-cycle, normal mid-cycle. Everyone will understand. All right, next one. And all right, let's have a look at this one. So this is this tiny one again. All right, so here we go. This is a typical uterus that you might get, benign uterus. And we've got myometrium, that's looking pretty good. And here we go. We're going to look at the endometrium now. And what do we think of this one? Well, I think this has been interesting. All right. So the glands are normally spaced, and I apologize for all this tiling. I won't use this site again. It's just too tily. They're not they're not very tortuous. And here we have glands, and they've got subnuclear, and then they've got like the clear bit, the clear evacuation has gone on the other side of the nucleus. So we know we're a few days later now, but this isn't really very stellate at all. So this is one of the complications of endometrium, all right? The glandular tortuosity can be out of phase with the changes in the cells, right? Which one wins? Are we going to call this secretory because it's got evacuation, or are we going to call this proliferative because it's got simple glands? What's it going to be? In the chat. Yeah, secretory. It is going to be secretory. Okay, it's going to be secretory because there is evidence that there is a luteal phase happening, but it's a pretty poor one. And in fact, some of the uteruses we get, of course, are in women with abnormal uterine bleeding because of fibroids or something, and they're old. The luteal phases aren't as good as they used to be. And so, but this is still secretory. Okay. Right, menstrual phase. Let's have a little look at menstrual phase. So here we are in lead. So this is a typical endometrial curettings. I don't think it's a papel because it doesn't have that kind of blood cast wormy look to it. And it's all pink. So what does pink mean? Pink can mean a couple of things. So pink can mean, well, pink can mean the staining's not gone so well. That is the first thing. Pink can mean that it's a polyp because the stroma is often quite fibrous. Pink can mean progesterone, and I wish there was some kind of mnemonic there. Progesterone, pink, polyp is probably the best you can do. So when we look at this, so I often scan at low power to see if there's cancer, and there isn't any cancer here. And when we look at this, we've got little glands that are spread quite far apart, aren't they? Nicely spread apart. Um, when we look at them, they only have one layer of cells. So we've lost that pseudostratification that we get with proliferative phase. So we know that something's happening here that is probably not proliferative phase. And some of it here appears to be having breakdown. So why do I think it's breakdown? Okay. I think it's breakdown because there should be a whole lot of blood and neutrophils here. So unlike other parts of the body, neutrophils in the endometrium does not mean acute inflammation. Neutrophils in the endometrium means menstrual phase. While a lot of the glands are kind of inactive, we do have the remnants of secretory stuff here. So we call these slightly inactive glands exhausted secretory glands, and these are the remains of the secretory glands. But often the clue to whether this is menstrual phase, and I'm just looking for it, is in the stroma, the little blue balls of stroma. All right, so there's some here because the stroma, as well as falling apart, you've got to think, oh, it's just the pressure being too much on the curettings or things. We get this stromal condensation. Okay, so often we talk about blue balls. All right, that is, I think, enough normal. Was that enough normal? Brief introduction to normal. Some hot tips about normal. All right. So we are now going to go here. So I've given the titles of this: active chronic endometritis in proliferative phase endometrium with squamous metaplasia. All right. Now, this is the other problem with the endometrium. Several things can happen at once. You can get metaplasia in a normal cycle with some actual pathology. So let's have a look and think about clues about chronic endometritis. Chronic endometritis is common in postpartum. Yeah, when there's a bit of retained products, you'll see lots of plasma cells there in the endometrium. It's pretty common where we've had a uh, um, IUD in for a long time. Yeah. So with the modern Mirena replace every 5 years, the a couple of plasma cells is fine. Um, when I was a young pathology registrar, we thought a couple of plasma cells were like, oh, it's definitely chronic endometritis, but that criteria has changed a bit. But you do get chronic endometritis with foreign bodies like coils in the myometrium. I had one the other day. It had been in for 21 years and had massive squamous metaplasia and also cancer that was very squamous. And I just wonder whether it had that. So right, approach this sensibly, Diane, and do not dive right in. So low power scan suggests that there is no cancer. Um, all right, we're going to play also a game of pathology bingo. Every time I mention a food stuff, you can write a score, and I'm about to call these donut glands. So we have the donut glands of here with the proliferative phase, and you can see the mitoses here. Okay, so what clue might we have that this might be endometritis? Because to be honest, I do not go and look at endometritis on every single biopsy. So there's the clinical clues, previous previous IUD. Also, the in endometritis, often the stroma has this kind of out of sequence streamy look. It's got this vaguely spindle cell look. You can see plasma cells from quite a distance away. So what am I on now? I actually can't tell, but I'm about 10 times. Okay, so you should be able to see a plasma cell from 10 times. So there we go. There are the plasma cells with their perinuclear HOFs. In this scan, because it's been done at 20 times, it's really hard to see the clock face chromatin. Yeah, but we have plasma cells. So how do I know it's so rules in looking for endometritis? Clinical suspicion. Look for streaming of the cells that is kind of out of keeping with the normal expectation of the menstrual cycle. And then look for plasma cells, but you don't have to go at 40 times after everything. Practice looking for plasma cells at 10 times. And we can see here that this is like good proliferative phase, endometrium, because of the endometrial stroma. The big pitfall is you've got tuboendometrial metaplasia in the cervix, and the cervix is full of normal plasma cells. So you can't tell whether it's endometritis if there's tuboendometrial metaplasia, like there's tubal metaplasia, unless there's really good endometrial stroma as well. So just seeing something with plasma cells and some dark glands that aren't typically those cervical mucinous glands, just think for a moment, is the stroma right? Is this, in fact, a bit of cervix that I've got hold of? But no. Okay. So I did promise you some squamous metaplasia. So you've heard of morular metaplasia. It used to be called squamous metaplasia, but it was confused with squamous metaplasia on the surface here. So I suspect this person might have had an IUD in the old-fashioned non-hormonal thing for a long time, because this is true squamous metaplasia of the endometrium. Okay, it's not cervix, it's squamous on the top. It's not the ball-like morular metaplasia that you get in the middle of glands. True squamous metaplasia due to a long-standing IUD, streamy looking endometrial stroma, plasma cells visible at 10 times. Good. Okay. Next.
Sorry, someone just asked the question in the chat.
Oh,
How,
good.
how many plasma cells do we need to see to call it? Is there an objective cutoff?
There is no objective cutoff. More than one or two. So more than occasional ones. Unless there's no Mirena or any other excuse for them. So with the Mirena, a couple normal. But here, like clearly tons. So clearly this is a good case. Let's say if you had five, I'd like hedge it and go up to up to 5 plasma cells are seen in a low power field. This raises the possibility of chronic endometritis. Please investigate further. Yeah, raising the possibility is a really good uh, thing to do when you are suspicious, but not like definite. Okay, here we go. Next one. Whoa, look at this. Look at this. All right, so a cancer scan. All right, you might look at this and think it's cancer. I have had cases sent to me on referral asking about this funny kind of cancer. Is this clear cell carcinoma of the endometrium? No, big pitfall. This is not clear cell carcinoma of the endometrium. This is the Area Stella um, phenomenon that is present during pregnancy, but can also occur during exogenous, high dose exogenous progesterone. Okay, so the glands are hypersecretory. They are crowded, but then crowded glands in secretory phase is okay. We don't diagnose hyperplasia on them. They are super, super corrugated. Look at them here. Right, so this is really, really tortuous, really grown longer than it is wide. And look at the cells, and this is why people get confused with Ariostellar reaction in cancer, particularly on a papel where we don't have good architecture. Some of these cells, they are just a little bit atypical. Where's the atypia gone? That you know how you can never find it when your consultant asks for it. Okay, so the registrars here, uh, all right, I can't show you great atypia at the moment, but they are just a little bit atypical, but they are not as atypical as clear cell carcinoma. Clear cell carcinoma, hyperchromatic, very atypical, sitting in the middle of the clear area of the cells, as many of these are, but these are not hyperchromatic. They can be a bit enlarged, but they are um, still quite smudgy chromatin. Okay, so this is a Ariostellar reaction, hypersecretory reaction. Um, what else do I need to tell you about this one? Over here. Okay, so this is the endometrium and this is the decidua. Okay, so here we are. We know she's been pregnant. We've got syncytial trophoblast and cytotrophoblast. It's either that or she's got a choriocarcinoma, but I'm probably betting on she's pregnant because we've got the hypersecretory stuff. And then we've got this decidualization around it. So let's have a look. I think that this is quite interesting as well, and I apologize for the quality. You see these glands in the decidua here, they've got quite prominent clear cells as well. Um, and we've got this pink decidualized stroma. So when we have progesterones, the glands often go quite atrophic, but these ones are hypersecretory and in the decidualized stroma. And as expected, we've got lots and lots of hemorrhage and inflammation of the retained products of conception. So over here, I'll see if it'll clear up a bit. We've got the decidua, okay, and then even on the top here, we've got this hypersecretory change. And of course, we've got lots of inflammation because it's retained products of conception. Okay, questions about that one? We're good? You've all seen this, haven't you? Yeah. No. Have a look around your pox and see if you can spot the hypersecretory change. This is like an exceptional one, but it will be in some of them. Okay. All right. So this is a full thickness uterus. I'm just going to point out some anatomy here. Right, we have this big vascular plexus in the outer half of the uterus, right? And this is kind of a cheat's way of determining whether it's in the outer half or not, because um, sometimes you don't get great sections and you can't, like, or the uterus is like so full of cancer that the walls become 2 millimeters thick and it's hard to tell whether it's on the no, inner half or out of half. Look where the large vascular plexus is. So if we're getting cancer around here, then we know that it's likely in the outer half. All right. Who can tell me why these blood vessels might have calcification in them? Type it in the chat, please. What's this a typical finding of? Janetta, good thought. Not atrophy, though, that this woman will be postmenopausal. So I'll accept two reasons. What? Yeah, okay. So she could have generalized arteriosclerosis. Yeah. Decreased estrogen? No, but she might have been pregnant in the past. Remember how high blood flow injures blood vessels? Yeah. And the highest blood flow state is pregnancy. So some older people can get calcification in vessels that have been somewhat injured by the high blood flow of pregnancy. Okay. Or she could have a systemic disease. But what we're thinking about is this. All right. This is autolysis, or as I like to call it, porridge. So, oh, man, I hate autolysis. The registrars here spend time opening uteruses so that we don't get as much autolysis in the uteruses. But sometimes, if there's cancer, it undergoes autolysis while it's still in the person. So, autolysis, it's not 100% the fault of the surgeon leaving it lying around for too long warm in theatre. Sometimes it just autolyzes. Okay, so we've got this autolysis, which makes it difficult to grade. So I'm going to address some of the practical things of endometrial carcinoma now. So what grade do you think this is? What grade would you grade this? Sandra suggested preeclampsia. Yes, could be high blood pressure from preeclampsia cause the damage to the vessels. But what grade is this? Someone write a grade in the chat, please. What grade is this? Hugo thinks it's a 1. What do other people think? Yep, Sarah thinks it's a 1. Come on, I want some more participation. I don't really care what you write. I just want you to write something. Yeah, almost all glands. Yeah, baliotolysis. So it's a 1. It's a 1. Okay, because this is just porridge. All right, so but all this is cancer or is it? Is it cancer or is it exogenous or is it atypical hyperplasia? So now we have another question. How do we tell all atypical hyperplasia from cancer, particularly in this autolyzed mess? It is grade 1, by the way, because you don't count the autolysis. And if ever in doubt, go look at the curettings. They will be much better preserved. If you ever want to do molecular, do it on the curettings. Do not do it on this. All right. So this is definitely cancer here, isn't it? Because we have many of the cancer big ticks. We have complex, large complex glands, yep, with atypical cells that are clearly quite, there's quite a lot of overgrowth in the middle, very complex patterns. We have what we call the string sign. So we've only got a string here of stroma between the glands. Yeah. Can we tell the difference between grade 1 endometrioid carcinoma and atypical hyperplasia on the cytology? This is a yes/no question. Yeah, Adam, yes, less than 5% solid is grading. So it's less than 5 to 50, and then more than 50. And if you're ever going 49 versus 51, I usually go down. I tend to overestimate the solid. All right. So the question I was asking was, can we tell cytologically the difference between FIGO grade 1 endometrioid adenocarcinoma and atypical hyperplasia? No, we can't. Well done. No, no, we can't, because we can't tell whether it's invasive or not. So cytologically, they're the same. So we have to look for the patterns. All right. Okay. So over here, this bit, I'm going to run through them. Are the glands overly complex? Yes, they are. They have these bars around them. Is there the string sign? Yes, there is. There is a string sign between these glands. Is there a desmoplastic change in the endometrium that will help us decide whether it's invasive? Probably not. Is there atypia above grade 1? No, no, there isn't. Um, so are we going to call this bit atypical hyperplasia, or are we going to call this bit invasive? So this is where it becomes hard and there are doves and hawks. If it looks like that, I would like it to please be treated like grade 1 endometrioid adenocarcinoma. Okay. So is the difference between atypical hyperplasia at the bad end different? No, it's not. So this is one of the kind of, it's nice to get it right and apply consistent criteria, and you will find them, written in the textbooks. It kind of looks the same as this very complex gland here and this desmoplasia. So there's something that's not in the textbooks, and that is context. Okay, so it looks the same as the invasive bit over here. So I would call all this invasive as well. All right, so here we go. We've got this slightly porridgey um, endometrioid adenocarcinoma of the endometrium. Um, how do I know it's endometrioid? What are the big clues for endometrioid here? Ah, so Adam, you've put must invade. So this is quite nuanced. If it is invading, it's definitely cancer, but you can get intraendometrial adenocarcinoma as well, where it's not invaded. It's like still in the endometrium, and sometimes it doesn't have desmoplasia. But if you follow the gland complexity, the string sign, the 2 millimeter uh, size, and the context, you'll mostly get it right.
And when you say that it can be not evaded, is that the EIN?
Yeah, yeah. So I hate EIN. It's American. Oh no, I'm generalizing. I don't hate all Americans. I keep having to remind myself. All right, I don't like the it is EIN, but okay, so endometrial intraepithelial neoplasia, I think is a really confusing term. So atypical hyperplasia, nice defined criteria, and its transition to endometrioid adenocarcinoma grade 1, both of which can be confined to the endometrium. All right. Um, they, the 2 millimeter gland complexity, string sign, context, help me sort it out. EIN is technically um, atypical hyperplasia. Okay. But it sounds like it might be grade 1 endometrioid. So I don't like to use it. I'm sorry. It'll be in Kurt's notes, I know, but I think it's atypical hyperplasia. Yeah. Okay. Where was I? Here we go. Why is it endometrioid? The string sign. The string sign is where you've got glands so close together that there is barely a couple of bits of collagen between them, right? So people say confluent glands. What does confluent glands actually mean? Confluent glands means the string sign. So barely a couple of bits of collagen between them. Can you see it there? Barely a couple of bits of collagen between them. Yeah. Back to back. What does back to back mean? It means a couple of bits of collagen between them, just like a piece of string. So other people might say back to back glands. All right. Endometrioid. How do we know it's endometrioid? By the shape of the glands and the stacking of the cells. Right. In low grade, it's easy because they have these cigar-shaped nuclei and they are pseudostratified. Okay. In higher grade, it's hard because they round up and start looking much more atypical, and you might confuse it with the serous. Endometrioid glands have a look to them, and this is the look. The cells are all lined up, pointing to the middle, and the glands, they're kind of, I'm going, the Kiwis in here will understand this. They are a bit like Lake Wakatipu. Okay, so here we've got Lake Wakatipu. All right, it's got some arms as it goes in and out. It's got like the Frankton Peninsula popping out. All right. Here we've got one that's a bit like Lake Wanaka. All right, it's still lined up around the outside. It's got an island in it because it's been cut through, but they kind of have that geographic look to them. All right, so we've got these long glacial lakes that occur in the Southern Alps. To the people who are in Australia, you're welcome to come and visit anytime. Whereas serous glands are much slittier. Right, we'll come to those in a moment. I'm spending a bit on endometrioid here, so because I want you to be able to fill in the report, right? So we have to know it's endometrioid carcinoma. We have to be able to grade it. What's the other thing? Actually, where I'd rather be. What's the other thing we have to mainly do in the endometrioid report? Everyone is writing. We have to stage it, don't we? We have to stage it and we have to measure the distance to the outside, which means that when you're cutting, you need to get a nice section of the bit opposite here, all right, opposite the cancer, because this is the best thickness that we're ever going to get. Imagine if the cancer was filling like half this and growing into the middle. Really hard to measure the distance to the lumen to the deepest point and think, where does the wall begin and end? Right? So this is the thickness of the wall, and then you measure the distance of the cancer to the outside. So this one here, we fortunately have a bit of benign over here. So I would say this is like 20 millimeters, and it is extending 18 millimeters from here to here. So it is 2 millimeters invasion. We do the sum. It's really hard, particularly in the bigger cancers, to work out like where the endometrium begins and ends. But I'm going to tell you a trick. So when cancers grow, they pull up strands of smooth muscle into the endometrium. So if it's vertically oriented smooth muscle, it's unlikely to be part of the wall where we've all got this kind of swirly, kind of going this way stuff. Okay, so that's a trick. If you can't do the measure the normal, measure the distance to invasion from the serosa, do the sum trick. That's the best way to measure them. The other thing that you will be learning to do is look for lymphovascular space invasion, but that is quite tricky, and we're going to move on. All right, so grade, stage, how to tell it from atypical hyperplasia. Yeah, have we got those down pat? How about you, Smither? You've written lots of these reports? No? Okay, you will. Don't worry. Right, let's go to the next one. Serous. Right, serous carcinoma. Here we are again. Serous carcinoma, the bad guy. Right. So when I said in serous carcinoma, the glands are much more slitty, can you see it now? Much, much more elongated. And the cells are kind of square rather than cigar shaped. One of the big clues for serous is that the amount of atypia in the cells is out of keeping with the amount of glands formed. Because if you're going, oh, it's endometrioid, there's lots of glands, it's grade 1, and then we go, oh, that's terrible. Look at them. They're awful. So glands out of keeping with the atypia and long, thin glands, right? But you're telling me, but like, aren't they meant to have papillae? Aren't they, where are all the papillae? Well, the papillae can be a bit subtle, all right? So here we've got the hobnailing and we've got these unsupported papillae poking into these glands. But here's here's the thing. Quite a lot of serous carcinomas will have just glands. Down in this bit, we do have true papillae. So before we had these like these papillae without cores, but here we do have papillae with cores poking into a space. So you can get just glands, just papillae, or a mixture of the two, but they always, always look horrible. Why do they always look so horrible? Please tell me in the chat. Why do they look so absolutely dreadfully bad? Yeah, P53. P53 has made the genome unstable and they are hypermutated. Well done. Thank you. These are bad, bad cells. All right, so here we go. Let's do the exercise again. All right. So now we've got a serous carcinoma. Great. We've confirmed it by doing a P53, an ER, and a DNA mismatch repair. Okay, so we do all those on all three. And the P53 is strongly positive in all the nuclei. Yes, we go. It looks like a serous. It's P53 mutated. Diagnosis confirmed. Is it invasive? Let's have a look. All right, the normal endometrium can be quite variable in its depth that it extends into the myometrium. So let's have a look. Is this bit invasive? No, that bit isn't invasive because we still have got endometrium around the bottom of it. Is this bit invasive? Maybe. So it's about the level of the normal glands. Does it have normal endometrium between here and here? Yes, I think it does. I think this bit is not invasive. Move across. Is this bit invasive? Possibly. Or it could have normal endometrium around it. Is this bit invasive? This bit's more likely to be invasive because it's kind of spreading out. So I look around. Aha, I go. Here we have some glands that are not in normal endometrium and have smooth muscle surrounding them. So here's a trick. Just keep looking, all right, for the invasion. You will find it eventually. And in this spready bit out here, okay, we've got smooth muscle all around these little glands through here. And once they've got smooth muscle all around them, it is invasive. And here's someone's made a mark on the slide, I think, to hopefully identify that this bit is definitely invasive. It used to be that you could maybe do a CD10 until they discovered it wasn't that good. CD10 stains endometrial stroma. Theoretically, you can find the end of the stroma with a CD10, but then they discovered that particularly endometrioid can induce CD10 positivity around it, and that was no good. Right, so let's decide what the depth of invasion is. Right, here we go. We're going to go from here to here, so it's this much. Ah, but this much is the same amount, okay? So in this case, you can't do this minuses because you know it's invasive, and so you just have to do your best guess. And to be honest, the difference between calling this 20 millimeters with 1 millimeter of invasion and 20 millimeters, 20 millimeters with half a millimeter of invasion is not going to make any difference. All right. So don't get too hung up about exact, just accept that it is like less than 10% invasion. These ones you have to look really carefully for lymphovascular space invasion in because they are more likely to have it. Serous carcinoma. Are we all good? Right, how are we doing for time? 2:52. All right. All right. We don't have too many to go, and then we can do the test cases. All right, here we are. Papel. So this is what we usually get, isn't it, to diagnose endometrioid adenocarcinoma, well, endometrial carcinoma on it. So let's have a look at it. At low power, we can see that this is cancer because it's got really large areas of hyperchromatism and glandular complexity. Let's have a look and apply our rules here. Okay, that's resolving a bit better. All right, so we've got this this cancer. We're having a look at it. And so we're going to try and decide whether this is endometrioid or serous and what grade it is. So we're looking around. Here we go. This has been cut too thickly to be scanned, by the way. That's why it's looking so difficult to read. 3 microns is what you have to cut them at to read. Here we go. So here we have these things. Do we think that these are small and square, or do we think these are shaped a bit like a kumara? So, right, kumara. We have some kumaras. We have some cirrus. Cigar shaped. Yes, cigar shaped. So these are more elongated. Are they in keeping with the gland formation? They probably are. And then you get this bit here, right? Which is a pain because this bit here has got square nuclei and is starting to be a bit slitty. Okay, tell me what percentage of endometrioid are mixed with serous? All right, we've got 1%, 10%, or 20%. You're very generous. So Tom's put 1%, and the answer is 1% or less. So it's not usually mixed. It's usually one thing or the other. If we did this, if we did a P53 on this, this would be really helpful. Okay, this would very much help us tell the difference between serous and endometrioid because the P53 mutated endometrioids only occur in high grade, and we think that this has got good glandular things. So if it's P53 mutated, it's more likely to be serous. And if it is not P53 mutated, it's more likely to be endometrioid. The other thing that will tell us that it's endometrioid is this stuff. Right, we've got squamous and morular metaplasia. What percentage of serous carcinomas have squamous and morular metaplasia? 0, 2, 5, or 10%? Adam said 0, 0, 0, 0. As soon as we see this, high five, not serous. Okay. So squamous metaplasia indicates that this is in fact endometrioid. So why is this looking funny here? Okay. It's kind of a combination of reactive change plus endometrioid. So areas in endometrioid can start looking a bit funny like this, but overall, the overall impression is that we've got cigar-shaped nuclei. We're sitting here on Lake Wakatipu and we have squamous metaplasia. Okay, next slide. Right. Right, polyps in old women are the one time that I do go on to 40 times and have a look at their epithelium. We can see that this is all a bit complex and funny around here, but we can see it's a polyp, it's pink. Yep. Serous carcinoma hides out in polyps. If I'd done a P53, these glands would be lighting up like crazy. This is serous carcinoma in situ here in this bit of the polyp. And I think this has been like, it's not a great slide, but these are really terrible cells. Okay, so polyps in young women that are looking normal, I'll go over it 10 times. If I see any hyperchromatism at all, I will be down there looking. But polyps in old ladies, I really, really examine hard. And we can see that this is like, it's got the horrible nuclei of serous and it's showing papillary. But here we've got it in situ starting in this polyp. It's really important. It can metastasize from in situ, right? It's important to find. So this woman will have, like if this was an endometrial polyp, it might be the end of it if it was taken out and you've missed the in situ. And if it was found, she would then go on to have a THBSO. Okay, so it's really important to look hard for it. Do you think we've got the kind of cytology of serous versus endometrioid sorted out? Yeah, good. Okay. Next. I think I missed this one out. All right. So we look at this at low power. Donuts, 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 not donuts. Okay. Atypical hyperplasia can be patchy. Simple hyperplasia, hyperplasia without atypia, is quite often uniform. Okay, so we're looking at this. We've got glands now that are complex with lots of infoldings. We're really concerned about this. Do we know it's in a polyp? Well, it's got the big glands of a polyp, but we can't tell on this that it's not in other places as well. We can tell we've got background proliferative phase, maybe mid-cycle because we've got the subnuclear evacuation. But here we have the crowded glands, and some of them are really crowded, like over here. So if I was doing this, I would measure it, and this would be about 1 millimeter. Okay. Tell me what I'm going to diagnose this as. Here we go. We've got some more bits over here. We've got a bit here that's 0.5 millimeter. What am I going to say? We know it's like really worrying because we've got these really complex glands. The glands are like more rounded than normal endometrial glands, and they've got nucleoli, which is what atypia is. They start to look squarish. They start to get nucleoli here, right? They're becoming really crowded. I mean, the cytology of this is like endometrioid carcinoma. What am I going to call this? You've got proliferations here. All right, good. So yes, atypical hyperplasia because it's less than 2 millimeters. Great. So we've got areas that look like carcinoma, but they're less than 2 millimeters. So I usually say atypical hyperplasia at least with some areas approaching endometrioid carcinoma that do not yet meet the criteria. I'm worried about this person. She needs to have workup to see whether she's got endometrioid carcinoma. She needs to have, a CT. She needs to have a discussion at MDM. And then because we know that endometrioid adenocarcinoma confined to the endometrium is treated the same as atypical hyperplasia, she either needs to go on to have a hysterectomy or she needs, if she wants to try and preserve her fertility, high-dose progesterone. Okay. Right. Adenomyosis. I'm sure you're all pretty familiar with adenomyosis, aren't you? Yep. So here's a nice example. Adenomyosis is only a problem for us when we've got atypical hyperplasia and invasive carcinoma because it messes up the measuring. So if you've got atypical hyperplasia becoming carcinoma here, that's invading. You still apply the same rules of measurement, okay? There was a big controversy about this about 10 years ago. The British said, no, it's only invading 1 millimeter. The Americans said, but it's in the outer half. The Americans won, okay? But generally, you'll give a spiel along the lines of atypical hyperplasia, a focus of invasion in the outer half of the myometrium, applying the FIGO staging rules. This makes it a 1B because it's in the outer half. Then leiomyomas. So there's a long discussion that you are due for probably in year 2 about leiomyomas. They can be quite variable because some of them get like infarcted, some of them are cellular, but there are very nice, clear rules around the number of mitoses they need to have and the type of necrosis. Unfortunately, the terminology for the type of necrosis is a bit confusing. So if I said to you, there's coagulative necrosis in the heart, what's it caused by?
Ischemia.
Yes, that wasn't a trick question. So you can get ischemic necrosis in leiomyomas, but dear God, you can also get tumor type necrosis, okay, where it survives around the little vessels, right? Tumor type, it's outgrown its blood supply. Two kinds of necrosis. When they first started classifying this necrosis, they called the tumor type necrosis coagulative necrosis. So if you're reading old textbooks, don't get confused. We now have ischemic necrosis and tumor type necrosis. And the tumor type necrosis is the small bits of necrosis without the hyaline around it, right? Whereas the ischemic necrosis is large blocks of ischemia with hyaline fibrosis, smooth fibro, that acellular fibrosis around it. Okay. Whoa.